All right, so I've been talking about courses, and the next nerve that is in for the list is ulnar nerve. So this is one of those nerves that's it's important, right? So it's the last one. So let's get over this. I'm going to get through that really fast, but most importantly, we have to know the clinical correlation of the nerve. So as you know, the ulnar nerve is a nerve of the upper limb, rises from the brachial plexus, and it comes down. So in contrast to the radial, which pierces the lateral intermuscular system, so this comes medially. So it descends down into the arm, passes behind the medial epicondyle, and then at the elbow level, it pierces the flexor carpi ulnaris and passes deep to that, together with the ulnar artery, all the way to the wrist joint, to the wrist, where it passes through the Guyon's canal, which is outside of the carpal tunnel. So this is a pretty straightforward, So as it goes to then after it goes to the hand, what it does is it supplies the hypothenar muscles, lumbricals, introsi, which is palmar and dorsal, and it's also known to give the innervations. There are certain muscles in the hand that get dual innervation. One is adductor pollicis, and another one is a flexor pollicis brevis, the deep head. So this is pretty much the course. You can probably tell it in about 15 seconds if you just know just the code, the main key areas. So now that you know the course, it's time to get busy with the information. So how can you do that? So the best way to do this would be to identify or imagine lesions at different levels. And ulnar nerve has something that's important that's known as ulnar paradox. I'll get to that. When we talk about it, you will understand it. Right. So in the forearm, you just have to know that it supplies the flexor carpi ulnaris as well as flexor digital profundus. Profundus is a dual supply, so it gets supply from the median nerve as well. But the median nerve supplies the more lateral aspect of the profundus, while this one supplies the medial aspect. So now let's look at the functions of the nerve in the forearm. Mostly, you will see that it is responsible for ulnar deviation of the hand, wrist joint flexion, and also the introsi responsible for what is it adduction abduction of the fingers, then hypothenar muscles, the little finger position, abductions, all those things are there. Then in lumbricals, again, as it's an important thing to remember, it is responsible for metacarpophalangeal flexion. So without them, metacarpophalangeal extension is what you will get. So I feel like these are things, muscles, these are some of the functions that you have to know so that you can actually understand the significance of this lesion, of the lesions. So come to the lesion at the arm, right? So if there's a lesion at the arm, pretty much everything below is affected. There's no doubt about that. There's nothing much to think there. So meaning but the thing is, like I said, flexor lesion profundus is dual supply, and so it can get supply from the median nerve, and it can do its function, which is wrist joint flexion. So wrist joint flexion would not be greatly affected. So what would be affected? The deviation, the ulnar deviation would be lost, so you will get more of a radial deviation of the hand. Then your hypothenar wasting, lots of intrinsic movements of the hand, and also hypothenar movements and all those things. And what you get here is something known as a partial glowing, right? So usually, so like I said, the ulnar nerve is responsible for the function of the lumbricals, and the lumbricals function is causing metacarpophalangeal. So let's say like this, right? So this is your metacarpophalangeal flexion. So without the flexion, now what happens is you get stuck into an extension, right? So you get something like a partial clawing. Then you can take a look at the middle little finger, right? So without, this is the normal metacarpophalangeal flexion. So without it, now you're an extension, and the function of usually this is the lumbricals. So lumbricals lose their innervation, so your now hands like this, but you don't get the full claw hand here, the typical ulnar claw hand. Why is that? Because right as of right now, because the function what actually is responsible for the clawing is the flexor digitorum profundus. So with that muscle also losing its innervation, like in the medial aspect, you start to see that the claw is not that prominent. So you get something, small, what you say, a partial claw hand or something like that. If that flexor digitum profundus was to get a greater supply, meaning if the lesion was lowered down, then what would happen is that the clawing would be more prominent because the flexor digitum profundus, it inserts in the distal phalanx, pulls it, and you get a claw, a prominent claw. So if the flexor digitum profundus gets the innervation, you get a claw. It's pretty straightforward, right? There's nothing much to really complicate, and that is basically your ulnar paradox. So right now, so we talked about the arm lesion, which so everything below is affected, flexor digitum profundus as well. But again, you have to remember flexor digitum profundus is well supplied. So you're basically everything else is everything is affected, right? And you're getting a partial claw, and your hypothenar wasting, then hypothenar wasting, introosseal umbilicals, and in addition to this, also sensory loss over the medial, dorsal, and palmar aspects of the hand. So that is just telling all those important things. So now let's come down to an elbow joint lesion. Now again here, let's assume your ulnaris or profundus is innervated, right? Let's assume that. So what will happen is, last time you got a partial claw hand, this time you get a much prominent claw hand because now the innervation has happened. This is what I was just telling. So yeah, so in addition to that, the rest of it will be same. There's not much of a difference, only the clawing is much more prominent. Everything below is affected. So what do you have? Hypothenar wasting of the umbilicals, introosseal, and sensory loss. Now come to which again what is that? The more hand will be more radial deviated. No. In this, sorry, in the elbow lesion, let's say if the profundus and ulnaris is innervated, then what is innervated will do its function. So if it's lower down, based on actually the innervation, right? So if the ulnaris is innervated, you will not see the radial deviation. If it is not innervated, you will see that it's weak and it's being pulled by the other side. Okay. So now come to the wrist joint lesion. So wrist joint lesion means you're going to have most of the hand muscles affected. Okay. So now the flexor muscles are really well. I mean, it's not going to be much of a difference. You're going to see a prominent claw, wasting of the hypothenar muscles, sensory loss. Lumbricals, introosseal. So you get a claw hand with the sensory loss over the medial and the medial dorsal and palmar, 3.5 dorsal palmar, dorsal and palmar, medial 1.5 fingers. Okay, so yeah. So in addition, so now if there's anything else that I would like to add, would be a Froment test, because this is some of the tests that you use to check at the hand level. So what does it exactly check? Now, for an example, let's say what muscle is checking is the adductor pollicis, right? So it's checking that muscle. So you keep a paper in between these two, between your thumb and your index finger, and you try to pull that paper. If you're able to pull it, then you can see that it's the muscle is weak. And also, most of the time, like there's something you can even naturally just think about. So median nerve, for the median nerve, now I'm talking about the ulnar nerve, but I'm not switching accidentally. But in the median nerve, you're checking for an OK sign because the profundus hits on the distal finger. So that way, if the profundus is gone, you will see that loss of that ability to pinch. And I believe it's even possible even in the ulnar nerve lesion. Right, so that is that.